Thank you, Joshua. And clinical professor of pediatrics, or a clinical professor of general pediatrics at UCSD School of Medicine, and chair of the Infectious Disease Committee of our local AAP California Chapter 3. We received funding for this project from a grant through the American Academy of Pediatrics and the CDC to improve pediatric infectious disease, natural disaster, and emergency preparedness. And I would like to introduce our other speakers. First, we'll hear from Dr. Mark Sawyer, who is a professor of pediatrics at UCSD School of Medicine and Rady Children's Hospital. And as you know, he's an infectious disease specialist. Then we'll hear from Dr. Eric McDonald, who's the medical director of epidemiology and immunization services branch at the County of San Diego Health and Human Services. And lastly, Deed Seidlinger will wrap it up with thoughts about communication and coordination between primary care and public health. And he also is with the County Department of Public Health as the Child Health Medical Officer. I wanted to just mention two things that caught my attention in the literature in the recent weeks that I thought I would share with you before turning the stage over to Dr. Sawyer. First of all, I don't know if you all saw that Bill Gates gave the Shattuck lecture, and it was reprinted in the New England Journal of Medicine in May. And I thought this quote was interesting, particularly in relationship to our discussion tonight. He said, "We can't predict when, but given the continual emergence of new pathogen, the increasing risk of bioterror attack, and the ever-increasing connectedness of our world, there is a significant probability that a large and lethal modern-day pandemic will occur in our lifetime." I think that's food for thought. And then lastly, the CDC published in a publication called Vital Signs, Trends in Reported Vector-Borne Diseases in the US and territories from 2014 to 2016. And there were 642,000 plus cases. But what caught my eye was that the annual reported incidence of tick-borne bacterial and protozoal diseases more than doubled during this period of time. So with that, to kind of set the stage, I thought I will now turn it over to Mark.
Okay, thanks very much, Isla. And thanks to all of you for joining us tonight. As sort of illustrated by Bill Gates's comment, one of the fun things about both infectious disease and public health is that things are always changing and there's always something new around the corner. And I have concluded after 30 years of doing peds infectious disease that the bugs are definitely smarter than us. So hence my title, Emerging Infections, the bugs are one step ahead and they're on the move. So what I'm going to hope to do during my presentation is give you some information about how you might be in a position to recognize that you're dealing with an emerging infection or potentially even identify a brand new emerging infection. So it may be obvious to everybody on the call, but clearly the reason we have such a potential for outbreaks of infection across the world is the mobile nature of our current society. And this is an old reference to Tiger Woods playing golf in San Diego on January 27th and in Dubai on January 29th. That's when he used to be good at golf, but it illustrates the point that clearly things can move around the world literally within 24 hours. And that has played out, as we all can remember, as recently as the Ebola outbreak, how much concern there was about Ebola being transmitted to other countries, and of course, including the United States. So I thought I would list some of the new outbreaks that we've dealt with just in the last 20 years or so, starting with H5N1 bird flu, which continues to be a threat and continues to be monitored. And then I've listed a number of others, with chikungunya coming to the Caribbean and parts of North America in 2004, Some of these viruses have not turned out to be very ominous, such as the human Boca virus, which was identified in 2005. But others, of course, you recognize as causing major outbreaks of disease with grave concern for pandemic potential and a real public health problem. So let's talk a little bit about how you're going to discover the next emerging infectious disease. And it all boils down to taking a travel history. Without a travel history, most of these infections are nonspecific, and you're going to have difficulty distinguishing them from your everyday viral and bacterial infections that you see all the time. And it's difficult to remember to do this in the hectic pace of an outpatient clinic setting, but certainly with children with fever and rash illnesses, you need to try to remind yourself to always take a travel history, because that's how you're going to start thinking about something that's out of the ordinary. So I'm going to share with you a little tour around the globe that reflects the kinds of things that we're currently dealing with. And of course, you don't necessarily have to go abroad to be exposed to a potential new outbreak situation. So I'm going to start in the United States. And I'm going to start with enterovirus D68 and acute flaccid paralysis that was first recognized in 2014. And just to share you a little bit of that story and illustrate how anybody on the front line is in the position to identify the next new emerging infection, this story starts with a single emergency medicine doctor in Kansas City who in the summertime noted an unusual increased incidence of severe asthma, including in children who had not wheezed before. He or she called the local health department, and that is one of the lessons for today's webinar. If you think something unusual is going on in your practice, call the health department. What did the health department do? They reviewed their laboratory data, among other things, and they noticed that there was a sudden increase in the laboratory detection of enterovirus rhinovirus that coincided with the clinical observation of these increased cases of severe asthma. They notified the CDC on August 19th, and by September 8th, a virus had been identified by viral sequencing, and an MMWR published identifying that this was due to enterovirus D68. So that also illustrates the rapid pace with which things can be investigated these days in public health. But of course, they can't investigate it if they don't know about it. So the first step is you interacting with our health department to let them know that something is up. Back in 2014, there were over 1,000 cases of enterovirus D68, and then it sort of disappeared. There were only 138 cases in 2016. The viral isolates from 2014 were genetically similar to previous enterovirus 68, so it wasn't a new virus, but it was clearly there in much larger numbers than we had ever seen before. It was actually first recognized way back in 1962 in California in children with respiratory illness, but then for the ensuing 36 years, it wasn't seen very much, and nobody has really explained what it was doing all that time or where it was. There were a few isolated clusters from time to time, but then suddenly in 2014, it really exploded. And then we're all sort of waiting each summer, which is the typical season for enterovirus, for it to reappear. And it's unclear whether it will or will not. Coincident with this outbreak of respiratory disease were cases of acute flaccid paralysis. And you can see the epidemiologic curve here with a peak in 2014 and then again in 2016. And this coincided pretty well with the initial outbreak of enterovirus 68. Another enterovirus, enterovirus 71, has been around for a number of years and occasionally caused small outbreaks. And I bring that up because right now in Colorado, there's been a recent report of an increased number of cases of enterovirus 71 leading to acute flaccid paralysis. So obviously acute flaccid paralysis is going to get your attention if it presents in your clinic. But this whole story just illustrates how things come and go, sometimes inexplicably, and the role of primary care providers in letting us know that things are happening. So let's go on our next destination, either to sub-Saharan Africa or Brazil. And that brings up a new outbreak of an old infection, yellow fever. We're in the middle of a large outbreak in South America, focused in Brazil, that started back in 2017. To date, or at least as of May 2018, there had been over 350 deaths, including in international travel. And that led WHO to expand the areas of Brazil for which yellow fever vaccine was recommended. And these are the recommendations. And for pediatricians, we should note that we're to recommend, it is recommended that travelers 9 months of age and older receive yellow fever vaccine if they're going to be in a high-risk location and in a high-risk setting, which has to do with their itinerary when they're traveling abroad. And for some countries, a yellow fever certificate is still required for entry, just to try to prevent the outbreak of or spread of this very contagious infection. Unfortunately, because of the outbreak, there's been, of course, an increased emphasis in immunization of the population of Brazil and other South American countries, and that has led to a worldwide shortage of yellow fever vaccine. I think that shortage has begun to be alleviated, but it's still an issue. If there's any questions about vaccination, you can refer to the CDC travel website. But the slide I'm showing here shows you the presentation of yellow fever with, as you can see, perhaps with the exception of back pain, is a very non-specific febrile illness, and it's going to be impossible to distinguish that from many other things unless you had a travel history that someone recently had been in Brazil. There is a biphasic nature of the illness that a subset of patients get. That is somewhat more recognizable, or at least raise your attention for something out of the ordinary, in that it presents with jaundice, bleeding, eventually shock, and organ failure. Our next destination is back to Brazil. Zika. How could we forget Zika? Zika was all over the media just 1 year ago. It too has largely subsided, including in Brazil, and we'll just have to stay tuned to see whether it recurs. Again, just as in the case of yellow fever, it's a pretty non-specific illness with a typical short incubation period of a viral infection, fever, maculopapular rash, and generalized symptoms which are not particularly helpful in making the diagnosis. So once again, if you have somebody who has had a travel history to a country where you know Zika is occurring and you get a patient with fever and rash, this is going to go up on your differential diagnosis and lead you to start thinking about it. Of course, as pediatricians, what we care a lot about is the incidence of microcephaly and other defects that were associated with Zika. That's what made it such a notable outbreak. Fortunately, as the dust settled, we realized that the overall incidence of these defects is relatively uncommon at only 5%, and with a higher incidence, as far as the data can tell so far, if the mother is infected in the first trimester. There are other findings, hearing loss, retinopathy, joint contractures that go along with the CNS involvement, but clearly that's the most important aspect of this unusual infection. And the evaluation, should you suspect you're dealing with a case of Zika, includes ophthalmology referral, a hearing screen, and of course, clinical genetics to help rule out other causes of the syndrome. This, I'm showing you here the differential diagnosis of Zika, which includes some of our friends that we are used to, or at least historically used to, measles and rubella, enterovirus, but also some of the other mosquito-borne infections, which we will talk about in a second, and dengue and chikungunya. So it's a very broad differential. And again, without a travel history, it's going to be hard to narrow this differential diagnosis down. There are a number of diagnostic tests now available for Zika. Nucleic acid testing is the most accurate and recommended using serum or urine. There's actually a so-called trioplex PCR. There's a typo on the slide that includes Zika, dengue, and chikungunya, which again, clinically look identical and are all spread by mosquitoes. And so this PCR test, which is now available at least through public health, will help differentiate an outbreak when it starts to happen in our community. There's new recommendations on pregnant women, that pregnant women who are symptomatic, who've traveled to an endemic area, should get nucleic acid testing. but that screening of asymptomatic pregnant women is no longer recommended. At the peak of the outbreak, we were screening asymptomatic women, and that led to a number of challenging situations, including false positive lab testing. So at this time, pregnant women are only recommended to be screened if they're symptomatic. Okay, our next destination, that's supposed to be the Caribbean. You may not be able to tell from that map. There is where we've seen recent outbreaks of both chikungunya and dengue, two other mosquito-borne pathogens. Chikungunya hit the Caribbean in large numbers in 2013 and spread to the Americas. There's certainly been cases, particularly in Southeast United States, and Dr. McDonald may update us on the epidemiology. These are transmitted by mosquitoes that are present in many areas of the US, including in San Diego, so there's nothing to keep chikungunya from coming to San Diego. The presentation, again, fairly nonspecific. The joint pain is something that may highlight for you that you're dealing with something other than the standard viral infection that we see so much of. But otherwise, it's a very nonspecific illness with a differential that overlaps all of the other things that we've talked about. The diagnosis, again, you're probably going to need help from infectious disease or the health department, but there is a serology and a PCR available for chikungunya. Dengue, again, clinically similar to the others. There are distinct serotypes, short incubation period. The interesting thing about dengue is that young children, when they're infected, are often asymptomatic, and with recurrent infections is when you get the more severe illness associated with dengue, which can include mortality. Almost all of the United States cases have been travelers to areas with endemic disease, including very recently Puerto Rico. So again, the travel history is what's going to make you start thinking about dengue. Now I'm going to take you to Western Africa, where, unless you were living under a rock, you will remember that we had a large outbreak of Ebola, which fortunately has quieted down since 2015, when there were 25,000 cases and 10,000 deaths. Young children seem to be at lower risk, so this primarily was not a severe problem in the pediatric age group. Unfortunately, there is a new outbreak right now in the Democratic Republic of Congo. Dr. McDonald may update us on that, but there were some 20 or 30 cases the last time I heard about it. Clinically, Ebola doesn't look that different than all of the other things we're talking about. So again, a specific travel history and some background knowledge of what's circulating in different parts of the world is what is going to help you get it to a specific diagnosis. And of course, much more common than Ebola are our friends malaria and typhoid fever, which remain endemic in many parts of the world. Incubation period, 2 to 21 days. Here, another longer list of symptoms, but you can see it's not specific until it gets very severe. Okay, my next destination is the Middle East, where you may or may not have heard much about the Middle Eastern Respiratory Syndrome, MERS, which is a coronavirus infection. Like other coronaviruses that we've seen in the past, including SARS, which was more or less a decade ago and had a very short outbreak that involved many countries, including the United States, and then disappeared again. MERS was first identified in 2012. There have been 400 deaths, so it's not a trivial infection. It presents with fever and respiratory infections, again, not very specific. Fortunately, to date, MERS has been confined to the Middle East, the countries listed there. As far as I know, there have been no cases that have originated anywhere but there. So if your travel history does not include the Middle East, then you're not dealing with a case of MERS. And if your travel history does include the Middle East, it should go up on your differential. So at this point, there's no treatment available. It's spread, we think, in part from person to person, but it originates in camels, hence the picture. So I would recommend not kissing any camels if you end up traveling to the Middle East. And finally, let me go to the Far East, where the birds are a problem, and I'm referring to highly pathogenic avian influenza. For me, of all the things we've talked about, the thing that makes me the most nervous as an infectious disease physician is avian influenza. And it's because there can be so many types and because we have no way to control the spread of wild birds as they fly around the world carrying these pathogenic strains. I've listed a number of them, and for years we were comfortable that H5N1 had not come to the United States, but I hate to break it to you, it is in the United States in bird populations. It's not yet been seen in any, as far as I know, in human populations. But beyond H5N1, the latest concern is H7N9, which has had a series of waves of disease in China and a few other countries in Southeast Asia, and is the most, seems to be at the moment, the most likely version of pathogenic avian flu to lead to a new pandemic. There have been outbreaks in domestic flocks, wild aquatic birds. At this point, antiviral prophylaxis is recommended for contacts. If you're going to travel to China or other areas in the Southeast Asia, you need to be aware of trying to protect yourself against transmission of a respiratory infection. For some reason, my slide is not advancing now. Well, I'm getting near the end of my presentation, so it's a good thing that my computer decided to stop presenting now. So I think what I'm going to do is summarize my presentation and turn it over to Dr. McDonald to fill us in on the public health or epidemiology of some of these infections and perhaps some new things that we will need to worry about. So if I can get to my screen, I'm going to turn the presentation back over and then let Dr. McDonald take over.
Dr. Sawyer, Joshua here. Are you able to stop screen share at the top center of your display? It looks like it's responding now.
Yeah, I'm getting there, I think. I have new share. How do I stop share?
There's the red button right on the green tab there. Yeah. Stop share. There we go.
There we go.
Thanks so much.
All righty. Good afternoon or good evening, everyone. I hope people can see my screen. If somebody can just give me feedback on that.
Yes, we can see your screen.
Wonderful. Okay. Well, thanks, Mark, for doing a wonderful job of talking about some of the emerging diseases that are out there. And I was asked to give a local update on emerging diseases and also to provide a sense of what your local health department does with the reports of illnesses from providers in the community. I'll mention several of the diseases that Dr. Sawyer just covered and a couple of extra of local interest. Our health department has oops, mine is not advancing very well here. Let's see.
Go ahead and click in the middle of the slide. Yes, you should have control now.
Okay, there we go. Our local health department has surveillance systems in place to monitor communicable disease in our community, and it's fundamentally based upon reports coming from providers, laboratories, and the general public on illnesses. We also monitor the pre-hospital and hospital systems daily to look for trends of illness, specific diagnoses that are being made, and symptoms that patients have. In turn, this activity leads not only to actions on our part, but feedback to you in the form of summaries of trends, alerts, and advisories, and recommendations on prevention and treatment. Under the California Code of Regulations Title 17, medical providers and others are mandated to report more than 80 diseases or conditions to the San Diego County Health and Human Services agencies. In addition, anyone in charge of any type of school is required to report, as are laboratories. To report a communicable disease, you can contact the epidemiology program by the listed phone number. And for urgent matters on evenings, weekends, or holidays, the 858 number is listed, and you can ask for the epidemiologist on call. You can also download and print a confidential morbidity report, also called a CMR, from our website and fax it to us. The levels of urgency for specific diseases and conditions are listed on the back of the CMR. Here are the diseases that must be reported immediately by phone when suspected or confirmed. I always find it a little daunting when a list like this shows up on a slide, but Dr. Sawyer mentioned some of these diseases, and a unifying theme here are that illnesses of public health importance are listed that may represent an ongoing threat to the public, such as one of the food poisonings, or one that requires immediate public health response by isolating people or quarantining close contacts, such as measles, or an illness that can be prevented by prompt post-exposure prophylaxis with an antibiotic or vaccine like tularemia or plague. Note the catch-all, any unusual disease or outbreak. That's your chance to identify something you think is unusual and report it, just as Dr. Sawyer mentioned in his talk. Here are the illnesses that are supposed to be reported within 1 working day. Again, some diseases were mentioned by Dr. Sawyer. There are some of interest for pediatricians, such as invasive Haemophilus influenza of any type in children under 5, chickenpox when there's an outbreak, hospitalization, or death, and several vaccine-preventable diseases. This list also has several vector-borne diseases. Most of these diseases are diagnosed by lab results, although there are 2, chickenpox and streptococcal infections, that laboratories won't report. It takes a provider to notice that there's a cluster of illnesses or a hospitalization or death to report it to the health department. And lastly, here are a few of the many diseases that are supposed to be reported within a week. But really, we'd like to hear about these as soon as possible, even when they're being suspected and well before laboratory confirmation, because the public health actions that we would be taking are important. For rickettsial diseases, for example, we would engage our county vector control to look for ticks in the area where the person lived or worked or played. And for mumps and German measles, we'd be looking for close contact. Collectively, all your reports on these diseases allow us to understand what is normal for our region and will prompt us to provide alerts to you when there is an increased concern about an emerging illness. We communicate these concerns by direct alerts to providers through news stories and the public. And here's an example of one of our recent health advisories on Ebola from last month. You can sign up for these alerts if you're not already getting them by going to the website KHAN San Diego and submitting a request. We also produce monthly summaries of reportable diseases in the county. Here's the most recent report. Each issue highlights a reportable disease, in this case STEC, and monthly statistics are presented on about 3 dozen reportable diseases. I'll be showing some charts from this report later in the presentation when I'm discussing some specific diseases. You can again sign up for this report by sending an email to the address on the screen. In the brief time that I have, I want to cover some select international infectious disease threats that we are closely monitoring here at the Health Department, along with the CDC and the California Department of Public Health. I'll also be discussing a couple of vector-borne diseases that are endemic in San Diego and a couple of vaccine-preventable diseases that are of interest locally. Let's start with a flashback to 2014-15 and the outbreak in West Africa of Ebola. That outbreak led to some increased preparations nationally and locally for infectious disease preparedness, with most local systems preparing plans. UCSD was eventually designated as our local Ebola assessment hospital, and the specific area in the Hillcrest Hospital for that assessment has since been disestablished, but local preparedness plans remain there and at Rady Children's if we have to ramp them back up again. You probably all recall the travel screening that essentially occurred everywhere. It was a bit too specific and was inefficiently implemented at many places, but we hope that the lesson learned is that where patients present for care and a communicable disease is in the differential, a travel history is being obtained. This map shows in red where there will always be a potential for an Ebola outbreak due to the presence of the bats that are the reservoir for Ebola in the environment. The star shows where the current outbreak in the Democratic Republic of the Congo, or DRC, is located. Back on May 3rd, the DRC reported a cluster of 21 cases of fever and hemorrhagic signs, including 17 deaths with illness onset dates starting in early April. After an investigation and confirmation of Ebola virus Zaire strain in 2 cases, an outbreak was declared on the 8th of May. The current status, as of June 17th, is that the WHO reports 62 cases and 28 deaths in 4 health districts in that province in DRC. As you have been likely following the news, WHO is responding with treatment and assessment teams, material support, Ebola vaccine, Doctors Without Borders is also involved. The real concern is that there are 4 districts shaded in yellow on this map, and although all the cases are coming from rural areas, the city of Bandaka, with about 700,000 people, is between 2 of those districts. And if it spreads there, then it may be another West Africa situation. But the good news, as you can see from this epidemiology curve, most of the cases had illness onset in May, and it appears that contact tracing to monitor for new cases is going well, with only 1 confirmed case with illness onset in June. So we have good reason to be hopeful that this outbreak will be contained. As of yesterday, there were 10 suspect cases under evaluation. Recall that the incubation period for Ebola is about 21 days, and the outbreak won't be over until it's been 42 days since the last case. As Dr. Sawyer mentioned, this disease, along with the others that he mentioned, are only a plane or a boat ride away, but travel patterns for individuals leaving the DRC are such that if any cases are seen outside the country, they'll most likely be seen in adjacent African nations or perhaps in Belgium, France, or London. Very few people travel out of the DRC to the United States, and the airport most likely to encounter these travelers is JFK in New York City. There are very few Congolese expatriates living in San Diego, about 200 to 300 people, a group that we first reached out to during the West Africa Ebola outbreak because there was a concurrent Ebola outbreak in DRC at the same time. So what can you do? Well, it's going to sound like a broken record, but obtain a travel history, and if a suspect case is identified, they need to be isolated. You want to contact your infection control and our local epidemiology program immediately. If you're interested in following this outbreak and others, such as measles in Liberia or Rift Valley fever in Kenya, you can get a weekly update from the WHO by signing up to the link that's provided. Just a quick word about a disease that's more likely than Ebola to arrive at a local provider's office or emergency department, but still kind of unlikely, MERS-CoV. MERS-CoV has been a little under the radar, as Dr. Sawyer mentioned, since it made headlines back in 2013 and 2014 due to cases in the Middle East, and then again in 2015 due to an outbreak in Korea that started with a single traveler returning from the Middle East. You can see in this epidemiology curve from the WHO, there were peaks in the Middle East in 2014 and 15, but there continued to be small numbers of cases constantly reported. Since the outbreak began, over 2,200 cases have been reported, including 790 deaths. This year, there have been 83 cases in Saudi Arabia, including 25 deaths. This chart shows the decreasing numbers of community-acquired and hospital-associated cases in the Middle East. This map shows the total number of cases that were reported from the various Gulf countries as of last week, and you can see that the vast majority, over 1,800, are from Saudi Arabia. So what can you do is to take a travel history for patients presenting with respiratory illness within 2 weeks of travel from the Arabian Peninsula, and even if they're mild symptoms, you'd want to contact us to determine if testing is warranted. The 2 big risk factors to consider are camel contact, including drinking raw camel milk or urine, which people apparently do, and visiting a healthcare facility. 3 specimens are needed for a complete workup, 2 respiratory and a serum specimen. The patient actually can be sent home with precautions while waiting for the test results. And for more details on MERS-CoV, we actually sent a health alert out on this last September, which is available online. Moving on to the diseases transmitted by the Aedes mosquito, Dr. Sawyer covered these nicely in his talk. The number of travelers from San Diego with Aedes-related diseases has dropped since 2016. In the last year, only 2 cases of chikungunya, 7 cases of dengue, and 17 cases of Zika have been reported. This chart is one of the ones that came from the monthly report that I told you about, and is updated each month with vector-borne illness reports. The information about Zika does change over time, and the CDC has a website that shows where current Zika activity is in the world. Here are the current countries and territories, about 80 odd. If you're traveling yourself or counseling a traveler, you can look up to find out what the current status is. There's no reason to expect to remember which country is on this list. There are countries and territories that were formerly having Zika transmission, but no local transmission has occurred in the last 12 months. They make it onto this list of areas with interrupted transmission that have negligible travel risk. Again, this website to find the information is the CDC's Travelers Health. It can also be reached from the CDC's Zika website. I'm going to show 4 maps of the United States that really illustrates what's been happening with Zika over time. This map shows Zika reports from 2015, before the outbreak really took off, with the darker the blue meaning more cases. And there were only 62 cases reported in 2015. In 2016, there were over 5,100 cases reported in the United States and over 36,000 in U.S. territories, mainly in Puerto Rico. The shaded areas on the maps indicate local transmission, including Texas and Florida. Here's the map for 2017, a lot less blue. Only 451 cases in the United States and 666 in U.S. territories. And here's the map for this year. Only 20 cases reported in the U.S. that the CDC's tracked and 62 cases in the territories. Now, these national numbers lag a bit. There have actually been 21 cases reported in California so far and not reflected in the national total, including 3 so far this year in San Diego. This map shows transmission of Zika in Mexico since the outbreak began there in 2015. The red state means there's been local transmission. Once local transmission has been established, and the Mexican health authorities tend to concentrate their surveillance on identifying symptomatic pregnant women. So a drop-off in case counts doesn't mean that there's less Zika activity. Just like the U.S., there was a decreased number of cases in 2017 with almost 3,300 cases reported, but this is when local transmission was first noticed in Baja California. There's never been documented local transmission in Tijuana. The closest the transmission has occurred is in the Ensenada municipality. In 2018, the reported number of cases has declined further to only 75 so far, but note that local transmission is being reported in Baja California Sur. And also, the mosquito season in Mexico is really just starting. This can be seen by looking at the 2017 reports of dengue in Mexico. Over 100,000 cases were reported last year, with 11 confirmed and 161 probable cases in Baja California. On this map, the darker green has the greater incidence of dengue, and the red state has the highest rate. And if we look at this year so far, only 11,500 cases have been reported, with about 30 probable cases in Baja California. Since probable cases are being diagnosed clinically and without lab testing, it's very probable that some of those cases are actually Zika cases, since the symptoms overlap so much. That's why we closely follow in the health department the probable dengue numbers in Mexico in conjunction with reported Zika cases to assess what might really be happening in Mexico. This epidemiology curve of dengue cases from 2017 onward also shows that we're just entering the dengue season in Mexico, so we need to follow this closely. On our side of the border, it's worth noting that we've been detecting the Aedes mosquito in many parts of the county already this year. The green dots are detections of the mosquitoes, which are all tested for Zika, chikungunya, and dengue, and none has ever been found here. This is the map from last year, and what it really shows is that the mosquito is where the people are in the county. These maps are available on the Vector Control website, and they're updated weekly. Here's the summary of Zika referrals in San Diego. Since the outbreak began, nearly 4,200 referrals, almost 4,000 of which were ruled out for Zika. There have been 108 cases diagnosed, with 2 from sexual transmission and 3 of congenital transmission. The rest have been travelers to Zika-affected areas. 40% were travelers to Mexico. We have some tests pending, and we currently get about 10 to 20 referrals per week, and we'd expect that to increase into the summer. If someone is potentially viremic with Zika, or any Aedes disease for that matter, we will send vector control to where the person lives, works, or goes to school to see if the mosquito is there. If so, control measures are taken. And in 2016, this meant spraying for mosquitoes 10 times, but since then, that hasn't been required. We've referred about 450 cases to our vector control. As to specific preventive measures for the public, you can go visit sdvector.com and learn about the prevent, protect, and report actions that they have detailed there. Here's an example of a handout that can be downloaded for education of patients. So you can also access information about other mosquito-borne diseases, and the one that's most important to us in San Diego is West Nile virus. There were just over 2,000 cases reported in the United States last year, and as you can see by this county-specific map, where the darker the green, the more the number of cases, Southern California was a hotspot, and it's been that way for a number of years. Over a fourth of all cases of West Nile in the United States were from California. As you can see from this county map of California from last year, where blue shows human cases and green shows West Nile virus activity but no human cases, there is potential for transmission throughout the state. The numbers are hard to see, but LA had the most with 277 cases, Orange had 33, Riverside 32. We only had 2 cases last year, but the year before we had 20, the year before that we had 40. And both Riverside and Orange have had hundreds of cases in the past, and we're concerned that we could have a year in which we have a large number also. The season is just beginning. Indeed, the first California cases this year were just announced earlier this week in Riverside, LA, and Kern counties. This map is updated weekly at the www.westnileca.gov website. If and when the first San Diego case is confirmed, we'll put a news story out on it. If you were to visit our county vector control website, sdvector.com or .org, you will see weekly updates on all the vector-borne diseases, including West Nile virus. Here's a map from that site that shows West Nile virus detections in the county. The black dots are dead birds, the green dots are positive mosquitoes, and the red triangles are human cases. And the pink box in Escondido was a horse with West Nile. These are the numbers from last year. And the take-home message is there's a potential threat from this disease all over the county. The county began to drop larvicide in May to reduce that risk, and they'll continue to do so into the early fall. So what can you do? Well, primarily an adult illness. We have had pediatric cases reported locally. So keep it in the differential for encephalitis, aseptic meningitis, acute flaccid paralysis, Guillain-Barré, and transverse myelitis. You could also promote the mosquito prevention messages. Another vector-borne disease endemic to San Diego is murine typhus, also known as flea-borne typhus. Throughout the world, this disease is caused by Rickettsia typhi and is mainly transmitted by rat fleas. But here in the U.S., it is mainly transmitted by the cat fleas, which is maintained in the environment by feral cats and possums. Most cases occur in Texas and in Southern California. In Texas, the cases occur in the spring and summer, whereas in California, we're just entering the peak season. Here is actually a detailed list of some of the symptoms you might expect to find from murine typhus. Fever, headache, and rash being the most common, but it's a pretty non-specific list. You can get serologic testing from our public health lab for murine typhus at no cost, which is a great reason to contact us if you have a suspected case. You can also get testing in commercial labs. Most cases are self-limited, why it's likely greatly underdiagnosed and underreported, but some cases can be serious with a reported 3% mortality rate. If someone's ill enough to be admitted with a fever of unclear etiology, they should be treated with doxycycline and this disease considered, especially because they can look a lot like Rocky Mountain spotted fever, which has a higher mortality rate untreated. We had a hospitalized case reported last month that was reported in this news story from earlier in the month. A woman in North Park who had an indoor-outdoor cat and recalled flea bites before she became ill. She was hospitalized, and the clinician quickly thought of the diagnosis because of the reported flea bites. In the story, we mentioned prevention activities such as flea control on your pets and removing supplies, food supplies outdoors and habitats for feral cats and opossums and wearing insect repellent. So what can you do? Well, you can think of this in the differential of a fever of unknown etiology in patients who are ill and just ask about pets and flea exposures, which may prompt you to getting lab tests to consider the diagnosis. You can also consider preventive messaging. I'm mindful of the time, I don't want to run over, but just a quick word on 2 other vector-borne diseases, tularemia or rabbit plague, a bacterial illness caused by Francisella tularensis. This is endemic to San Diego. Our vector control had not detected it here in local ticks in the last 3 years, but just in the last few months, we have been detecting it. And while we have had no rabbit die-offs, the increased detections really should increase awareness. I would direct you to the CDC's tularemia website for details on presenting signs and symptoms. And again, there's a map on our website that shows the detection in green. Is where we've been finding the ticks positive. Most of them have been in and around Lopez Canyon, which is just above the 5805 merge on this map. The last local vector-borne disease I'll mention is hantavirus, which is carried by the little critters seen here. Clockwise from the upper left are the deer mouse, the cotton rat, the rice rat, and the white-footed mouse. We've actually already had 2 cases of hantavirus in California this year, which is earlier than normal compared to previous years. And while we haven't had a local case in several years, our vector control program has been increasingly finding positive mice within the county. And then, as you can see on this map, the little pink dots show where the mice have been found. And the most recent finding was near Warner Springs last week. But you can see they've been found as far north as Fallbrook and as far south as the US-Mexico border. So essentially another potential threat across the county. I only have time for a brief word or two about vaccine preventable diseases of interest, and I'll just mention 3. Of course, the big one is influenza. I think you're all aware of the severe season that we had in 2017-18, approaching 21,000 lab-confirmed cases in the county with 300 ICU cases and 341 deaths. Most of those were over the age of 65, but 2 were pediatric cases. And 117 outbreaks, mostly in skilled nursing facilities and assisted living and congregate living. I think everyone's familiar with our recent hepatitis A outbreak. There were 6 cases in 2016, 571 in 2017, and so far this year there have been 12 outbreak cases. Marked in red on this epi curve are the dates that our first health alert went out when we noticed the increase in cases of persons experiencing homelessness and illicit drug users back in March of 2017. And then the week that the health emergency was declared, the first week of September, and then also the week that the emergency ended in January of this year. We're very hopeful that we've returned to our baseline of about 2 or 3 dozen cases reported each year, usually in international travelers. And I just want to recognize the great work that was done in the community to immunize everybody. There were only 2 pediatric cases in this outbreak. Both of them had not been immunized. And my last slide to show is another chart from our monthly report showing select vaccine preventable diseases reported in the county. As you can see, the hepatitis A cases in blue are tapering off over the last 12 months. There were a total of 15 mumps cases in 2017, which are in green. You can see the tail end of those towards the end of 2017. And there were 1,161 pertussis cases reported in 2017, and that's the orange bars, with about 60, with anywhere from 60 to 140 cases reported each month. Now, May looks a little low on this graph, but there are reporting delays, and this will go up. So hopefully I've given a quick and dirty overview, and that's all I have, and I'll leave it for questions, and actually I'll pass it to Dr. Seidlinger if I can figure out how to do that. So stop share, and I think it's to you, Dr. Seidlinger.
Yes, it is. Thank you. Let me see if I can get mine up. The right screen. And hopefully you can all see my slide. So thank you for...
Doctor, there we are. We see the slideshow now.
Yeah. I have to go through a couple of extra steps to get you to see the slides, but thank you for giving up part of your evening for this talk. I think as we had been meeting as an infectious disease committee locally, we knew that there's a lot of things that our local public health department was doing and that you as providers are doing to kind of respond to some of these new and emerging infections. And you know, we're stronger when we do this together, so we wanted to really take some opportunities to highlight some of these things, and hopefully we will get you all out soon so you can see the beautiful sunset tonight if there is one. So I'm just going to wrap up a few things and reinforce some of the things that you heard from Dr. Sawyer and Dr. McDonald and Dr. Boyes earlier. Our KHAN San Diego, or our California Health Alerts, are one of the best ways that we have of communicating information to you as a provider community. KHANSanDiego.com is the website. All of the old health alerts are referenced there. So when Dr. McDonald said that we had an alert from September of last year, those are archived on this website. And there's also ways here to subscribe to these alerts. We do try and send out the alerts that are we think are most relevant to pediatric patients through the local AAP chapter, but sometimes there's a lag in that. So signing up for the alerts is quick and easy. And for those of you who used to receive our eMan alerts or our older health alerts and were frustrated by having to reset passwords, that is no longer needed. And so you will get an alert and can just click on the PDF and read the alert without having to remember a password. So we encourage you to sign up so that we can communicate directly with you and send out important information about local events. Many of the things that Dr. McDonald talked about are linked on this website for our epidemiology program, which is sdepi.org is the shorthand way to get there. And we post the monthly communicable disease reports here. During the influenza season, we post our influenza reports here. And each of those reports has a link in the report or an email in the report to sign up and receive those emails directly. I think these are a very nice adjunct to those who get the respiratory pathogen emails from Rady Children's Hospital during the season to show what's going on locally and keep abreast of what's going on. In addition, on this website, it has full lists of what are the reportable conditions and how to report them. I put the numbers here as well, the daytime number and then the urgent after hours number. And again, if you have questions, taking that travel history for any of these patients who present with a febrile illness that you're not sure what's going on is great. But if you have questions about what you think might be going on, picking up the phone and calling us, we can talk through some of the things to suspect or not suspect. We're here to partner with you to try and protect the public's health here in San Diego. So the ways we have of getting out information is we really hope that our providers, that you as pediatricians will sign up to receive alerts and reports. We do archive those on our county website, so you don't have to save those and clutter up space on your computer, but know those couple of quick websites where you can get all those KHAN alerts, influenza reports, and communicable disease reports in one place. Getting those into your email so you can scan and see what's going on in the area. We do know, and all of us who deal with EHRs know that we can get so many pop-up boxes that we're overwhelmed by information. And so working through our infectious disease committee, which has representatives from most of the major pediatric groups, trying to get a way to say if there's something that elevates to a need to change practice, to change testing, to change the questions we're asking that's really urgent, to try and use almost a communication tree through that group to have peer-to-peer communication about some of those very important alerts that come out. I just wanted to mention a couple other resources that some folks may be using to get information, and they're very important, but they're complemented by our local information. Many people are signed up for ProMed or the alerts that come out from the International Society for Infectious Diseases. Can be an important source of information. If there's anything that's pertaining to us locally, we will put out a health alert and get that information to you as well. Some people use CIDRAP from the University of Minnesota, the Center for Infectious Disease Research and Policy, that summarizes many of the same things that are in ProMed and sends out some daily emails throughout the week. And also the CDC does send out health alerts. Again, if there's something that the CDC is following that is going to impact us locally, we will package that and give you the local resources that you need and send out a health alert. And just because not all disasters are communicable diseases and the way we respond, just a little push for readysandiego.org. If you're not signed up for alerts or you don't have the app on your phone, that's a place where the County of San Diego and the local municipalities push out information when we have a local emergency, like a fire, earthquake, or something else. And so you can get those alerts to protect yourself and your family, but also your coworkers in the office and what your patients might be going through. So a little non-communicable disease push, since we are getting some funding around disaster preparedness, I thought was important. So that's all I have, and I think we're going to turn it over and see if there are any questions. we'll have these slides available, and like I said, those couple of key websites where you can sign up for alerts and get more information are very important. I'm going to stop sharing my desktop.
Thank you, Dr. Seidlinger, Drs. McDonald and Sawyer as well. That was excellent. We have at least one comment / question from Melissa, who has a reminder, and actually I think it prompts a question to Dr. McDonald about providing and offering the follow-up hepatitis A vaccine. In pediatrics, we're pretty tuned in to giving that second dose, but I'm wondering about all the adults in the outbreak, what efforts are being made to make sure they get their second dose of hepatitis A vaccine?
Sure, I'd be glad to address that question. Well, for outbreak control purposes, the first vaccine is the most important, and I'm going to knock on some wood that it looks like we have our outbreak under currently control. But for each specific individual, it's important that they get their second dose so that they can have that lifelong immunity. And the county is actually involved with a major push right now to get those second doses. I think it's called our Due for Number 2 campaign. And so we are trying to outreach, and it's actually quite gratifying to see how many of the individuals who are experiencing homelessness who still have their cards and in fact can tell when they're due for a shot, and we're in fact giving it. So I think somewhere between 12 and 15% of the shots we've given so far are in fact second doses, and that percentage will increase here now that we're just passing the 6-month mark of the peak of when we were giving shots.
Thank you. I think that's helpful. We had one other question, but it disappeared from my screen. I do have a question or two. Dr. McDonald, you mentioned that there were, I think, strep and maybe chickenpox are reportable and not automatically reported by the lab, only if it's in an outbreak situation. But I was wondering, how important is it for us, for those other diseases that the lab reports, for us to also report? I find that oftentimes by the time I have the report in my hand, usually the county health department already knows about it. But should we be reporting that in addition, those cases?
Yes, I think that's a great question. And the first is sort of the legal answer is there's a separate mandate that providers report regardless of what the laboratory does. But even though we do get reliable reporting from laboratories, sometimes it's delayed or sometimes it doesn't happen at all. And so it is important, especially when a provider is suspicious or highly suspicious of a diagnosis. We can actually save an awful lot of time if we get that call when it's highly suspected rather than waiting until the laboratory comes back. You also, on that list of diseases that were in the call right away category, there were a number of diseases that are really only clinically diagnosed. So most of those food poisonings, hemoleucuremic syndrome, these are things that must be clinically diagnosed so that it's the provider that's going to give us the only word that we're going to get on those diseases.
Okay, thank you. I'll keep that in mind. If I may ask another question, I was curious when I read the statement from Bill Gates about potential bioterrorism, and I was wondering if the county has preparations in place for bioterrorism and pathogens that may be implicated.
We do, and if you notice that a lot of those diseases that were on the call us right away list were diseases that are important from the bioterrorist perspective. We actually have the capacity in our public health lab to test for a lot of those diseases. So, for example, a veterinarian reported a cat who he thought had plague a couple of years ago, and we were able to get a sample from that cat and immediately determine, well, it wasn't plague, but it was actually tularemia, which is another disease of bioterrorist importance. And the good news is we got that word right back to the vet, and the cat was treated and did well. But that local capacity to be able to turn around a quick answer on a disease of public health importance that could be used by a terrorist is something that we have.
Thank you. Another question came in, and I think Dr. Sawyer might be a good one to answer it. I have a vaccine question. My question involves the timing of the fourth DTaP. I know that the ACIP recommends giving it at 15 months. However, where I work, they really want me to give it at 12 months at the well check, as long as 4 to 6 months have passed since the third. Is that going to give us good protection, or should I try to give it at 15 months?
No, I think the best recommendation is that, or ideally you should have 6 months as an interval between dose 3 and 4, although 4 to 6 months is acceptable. 6 months is really the best. And so for many kids, if they come in at 12 or 13 months of age, it has been 6 months since their third dose, and it's fully appropriate to immunize with the fourth dose at that time. And we continue to see pertussis in the community. So personally, I'm in favor of immunizing as soon as you have the opportunity.
Thank you. Are there any other questions? If not, I have one other plug that I'd like to make. I think that the fellow presenters tonight who all sit on the Infectious Disease Committee will agree with me that we're always open to new members throughout the county. Our committee is made up of a number of individuals. We try and get representatives from the major practices, but I know many of you may practice in a smaller setting, and we welcome members to come. We meet quarterly, and you can contact, I'm going to speak for Meredith and Cindy, them at our AAP office. So I think more members, the better in this effort to track our infectious disease and have a rapid response to any problems that come up. Does anyone else have anything else they want to say? Well, thank you. I think it's been very informative to me. I've learned quite a bit tonight.
Okay, thank you, Isla.
Okay, we had a, okay, thank you very much.
And thank you for your attendance here this evening. We do appreciate you taking the time out of your busy schedule. And we want to remind you that today's session is being recorded, and you will find it at the aapca3.org website within about the next week. Thank you again for your time. Enjoy your evening.